Hello, everybody. Thanks for the opportunity to participate virtually. Can you hear me okay? We good?
Yes.
Thanks. So I grew up in Cheyenne, Wyoming, which is about 3 hours down the road from where you are. And Colorado Springs was one of my favorite places to go. So I hope you're all enjoying it. It's a absolutely gorgeous part of the country. I'd like to talk to you about diagnosis and diagnostic error. I've been working in this field for about 20 years. It's a very annoying problem for those of us in healthcare who are interested in safety. About a decade ago, I founded a nonprofit group called the Society to Improve Diagnosis in Medicine. And we're envisioning a world where nobody would be harmed by diagnostic error. We are a long way from that. We believe that diagnosis should be accurate, timely, efficient, and safe. That shouldn't be too much to ask for. There are a lot of resources on our website, and if you'd like to learn more about diagnosis or diagnostic error, please give us a visit. This is what I'd like to cover with you today. Talk a little bit about diagnostic error, how likely it is that one will happen, why do they happen. I'd like to review very quickly some of the things we'd like to see in terms of addressing the problem and reducing the likelihood of error, and also talk about diagnosis in the context of high reliability. And it's great that there's so many people at the conference who have interest and expertise in that area, because we need help. We've kind of reached an impasse as best I can tell, and some suggestions on where to go from here and maybe getting some new people involved would be terrific. So what do we mean by a diagnostic error? Turns out there's probably half a dozen different definitions out there. But I think if I give you a story of a diagnostic error, it'll make perfect sense. This is a story of Rory Staunton. This was in the news about 10 years ago in New York City. Rory was a 12-year-old boy. This was right after the miracle on the Hudson. You remember that? Sully landed the plane right on the Hudson River and saved everybody's lives on the airplane that engines had been knocked out by geese. And Rory thought that was amazing and wanted to grow up and be a pilot. He'd written a letter to Sully. Sully had written him back. He did a helicopter ride around New York City for his 12th birthday. And shortly thereafter, he's in school at recess. He dove for a ball, and scraped his arm. Didn't think much more about it. 3 nights later, he wakes up in the middle of the night. He's got a fever, he's got chills, and he's vomiting. The next morning, he's worse, can't go to school. Family gets him an appointment at the local pediatrician, which is great to be able to get in that quickly. And these are the vital signs at the pediatrician's office. His temperature's 102, that's up there. Heart rate of 140 is kind of a red flag. That is way up there. Respiratory rate is 36. His blood pressure is okay for a kid. And the pediatrician described his skin as mottled. We don't have a picture of his skin, so this is just a stock photo from a medical textbook of mottled skin. The technical term for this is livedo reticularis. It's kind of an unusual finding and another red flag. You don't see this every day. His abdomen was benign, which is relevant because the pediatrician, getting this story of a school-age kid who's febrile and he's throwing up, thought that he had gastroenteritis, the stomach flu. And that's a perfectly reasonable diagnosis given this set of facts. And she recognized that Rory didn't look good, called up the local emergency room. Hey, I'm sending over Rory. Take a look at him. I think he's got gastroenteritis. So here he is in the emergency department. And this is at a hospital that bills itself as the #1 hospital in the country. Vital signs are about the same. Abdomen's still benign. There's no mention of the skin. And they say, sure, gastroenteritis. And they give him some medicine for nausea and give him some fluids, send him home. After he gets home, his CBC comes back, the results of his blood tests, and his white blood count is elevated, not much, just a little, but he has 53% bands. And bands is something you see with bacterial infection. You don't see bands with viral gastroenteritis. So that's another red flag that kind of went by the wayside. And this was after he had already left. Here he is at home the next day, he's worse. Family says they'd never seen anybody's skin look like this. His skin was sensitive to touch. It was blotchy, red and blue. They tried to get back in touch with the pediatrician, never really succeeded. Somebody from the office said, just take some Tylenol. The next day, they couldn't stand it anymore. They took him back to the same ER. He was admitted immediately to the ICU, but it was too late. He died the next day of streptococcal sepsis. So this is an example, a sad one, of diagnostic error. In all likelihood, he never had viral gastroenteritis. He was probably septic from scraping his arm at recess, and it was unrecognized at both the pediatrician's office and in the emergency room at the first visit. So this is what we mean by diagnostic error. It's very clear that a mistake was made and it had a horrible outcome. What do we know about diagnostic error? Well, we've learned a lot from malpractice claims data. So if somebody files a malpractice suit for a diagnostic error, this data is recorded and a lot of it is coded. So you can search these claims to see why it was filed and what the common elements were. And these are just some of the major findings from those kinds of studies. Diagnostic error is the most common reason that a patient files a malpractice claim in many or most medical specialties. It's the most catastrophic kind of claim. 64% of these claims result in death or permanent disability. It's a top 10 cause of death. We'll see a little bit more on that in a minute. And it's very costly. The median payout is higher than for any other kind of medical error. It's the number one thing in terms of cost. And this is some research data on how likely it is that there be a diagnostic error. The gold standard comes from autopsies, and there are still places in the world, and actually a few in the United States, where they still do a lot of autopsies. And what's found is that there is a major unexpected finding 10, 20, 30% of the time. So this is something that was discovered at autopsy that was not apparent or realized during life, or vice versa. Surveys of adults find that 1 in 5 patients have experience with a medical error. Most of these are diagnostic errors. If you survey people over 60 or 70, that number goes up to 1 in 3. Chart reviews done of primary care patients find that 1 in 20 patients seeing their primary care provider will have a diagnostic error every year. So, if you see your primary care person every year for 30 or 40, 50 years, and you've got a 1 in 20 chance every year, you can see how these add up. My favorite kinds of studies from a research perspective are the ones where they used standardized patients. And these are just fascinating kinds of things. So these are like secret shoppers. They take an actor or an actress and they train them to portray somebody with a classic condition in internal medicine. And they send these people into internist's office and they see how they do. And the internists get it right. Well, in this study, 87% of the time. They miss it 13% of the time. And these are classic presentations of common conditions: rheumatoid arthritis, COPD, heart failure, asthma, things like that. So at this point in time, our gestalt of how likely a diagnostic error will be is down at the bottom there in the visual specialties. So this would be like dermatology, looking at somebody's skin, pathology, radiology. These people are pretty good, and their error rate, we're pretty sure, it's not 0, but it's better than the rest of us. They're down around 2, 3, 4, 5%. In internal medicine, so this would be primary care, pediatrics, family medicine, probably 10 to 15%. And in the medical specialties, we really have no idea. There's like no data, almost no data at all on that. So that's kind of a summary from the research studies. But what I'd like to point out is that these are research findings. I really don't know what my own rate of diagnostic error is. I don't know what anybody else's rate is. And there's right now not a single healthcare organization or practice anywhere in the world that I know of that's measuring the rate of diagnostic accuracy, which is kind of sad, and it's data that we really do need. This is what it adds up to. estimated 40 to 80,000 deaths a year from diagnostic error. And this is an estimate from about 20 years ago. More recent data would put that probably 5 times higher. So many tens of thousands of deaths, clearly in the top 10 causes of death in the country. And if you divide this by the 5,000 hospitals in the country, it means that every year in every hospital, on average, there's 10 deaths from diagnostic error. And we've already seen the data that 1 in 20 primary care patients will have a diagnostic error. So these are instances where there will be the likelihood of, or at least the potential for harm in clinics or in the emergency department every day in every setting. Everything we know about diagnostic error, at least through 2015, was summarized in this wonderful report from the National Academy of Medicine called Improving Diagnosis in Healthcare. If you really want definitive information, the state of the art, this is the place to go. And this is a quote, their conclusion about the likelihood. It's likely that most of us are going to experience at least one diagnostic error in our lifetime, and some of these are going to have devastating consequences. All right, and why do they happen? Well, diagnosis is complex. And you've been talking about complex systems already for a couple of days. So, airplanes are complex and space missions are complex, but I would present the case that diagnosis is much more complex than any of those. To begin with, there's over 10,000 diseases. We really don't know the exact number, and there's new ones discovered every year, but there's only 200 symptoms, more or less. So for any symptom you might have, there's 50 different possibilities, and they all look pretty similar in many cases. That's the start of the problem. The second issue that we confront is that there is complexity and variability across the board. It affects our patients, it affects our healthcare systems, which are getting more complex by the month or the year, and certainly physicians. We are not all identical. Our knowledge and our experience is different. We're not even the same from day to day. And who knows what our local environment is the day that Rory Staunton came in. Maybe there were, 50 other kids at the exact same time, and they only had 2 minutes for Rory. We really don't know. So lots of factors contribute to making diagnosis a challenge. One of the nice things in that report from the National Academy was their description of diagnosis as a process that plays out over space and time. And this has been very helpful from a research perspective because you can start to dissect things out and study the individual parts. So it starts off with a patient experience a problem like Rory, and then him engaging with the healthcare system. That was pretty good. That happened just the next day. And then the circle is, where all the action takes place. We get the history, we do a physical exam. Hopefully we do it well. We try and figure out what's going on. This is iterative. And hopefully we come up with a diagnosis or at least a plan of action. We communicate it, we get going with some tests or with treatment. And that red line is very important. This is where we're supposed to learn about how well we did. What was the outcome? Did I get it right? And by and large, that red line doesn't exist in healthcare today. There's almost no learning of any sort. This is a study done by Gordy Schiff, who's an internist. He gathered 583 cases of diagnostic error that people voluntarily reported to him. And he looked at where things break down in the diagnostic process. And you can see we are not really perfect anywhere. There are problems all across the board. But by and large, the bulk of these occur in the clinical reasoning phases, in that circle, where you're trying to figure out what's happening. You're putting together the facts and your knowledge of medicine, what's going on, what test should I get, what consult should I get. So like 75% of the time, the error is in that particular part of the diagnostic process. I use a different approach to thinking about diagnostic error. And if I'm going to do a root cause analysis or something like that, I find this very helpful. So, here's Rory Staunton going along his way in the medical domain. And that red star is where the diagnostic error takes place. And this is the sharp end of medicine. And it's perfectly appropriate to say, Mark, here you are in the emergency room, you're seeing Rory. Why didn't you think of sepsis when he was there? And it gets at the cognitive causes and contributions of diagnostic error, which are huge and really important. But actually, the National Academy, if you go back to Error is Human, would say, don't waste your time on Mark because he's learned his lesson. He's not going to miss sepsis again. We should focus on the system, the blunt end, because if we can fix something there, we've made healthcare system safer for all of us in the future. And here's where we're talking about, the things that influence how well we do. What's communication like in our system, and coordination of care, and how well are the staff trained, and do we have good policies and procedures, and on and on and on. So this is the sharp end and the blunt end. So if you think about the blunt end, the system errors, what kind of problems do we see in cases of diagnostic error? And it's a very long list, but these things are at the top of the list. The number one thing, like in all safety analyses, are breakdowns in communication. And there was one here, the CBC was kind of late getting there. That result was probably available earlier. There's many instances where the lab results are just completely lost and nobody's looking at them. A good example would be if you're in the hospital. About over half of people who leave the hospital have test results that are still pending. 2/3 of those, nobody ever looks at those test results. That's not good. Access to care. So it was pretty good in Rory's case, but personally, if you're trying to go see a specialist, you may have a 4-month delay before you can get in to see somebody. Is there proper expertise available? For example, many emergency rooms today do have stroke teams and many do not. How's the culture of safety? Is it good? Is it bad? What's the daily environment like? Are there too many distractions? Is the workload excessive? What's the reliability of the lab and x-rays? Burnout and fatigue are a huge problem today, much more so than in the past, and that's getting worse, as I'm sure you all know. The thing that was new to me, and this was a learning experience, is this business at the bottom, the normalization of deviance, and I'm guessing you all know what that is, but it was new for me. And this is where, things are bad, but you've just gotten used to them, and you just accept them and move on without addressing the problem. In the hospital where I worked, this was a small hospital, and on the weekends, we did not have a radiologist on call or in the hospital. So if you came into my emergency room, you were seen by the moonlighting endocrinology fellow. And that was great if you had hypothyroidism or something, but every year we had 2 or 3 or 4 diagnostic errors where the radiologist would come in on Monday and say, oh, the patient you saw who was short of breath, here's this little pneumothorax that you missed. And that was normalization of deviance. We knew that we didn't have a radiologist, but none of us complained because that's just the way it was. And we were told we couldn't afford that and get used to it. It turns out, at least in my case, that the cognitive errors are much more interesting. And that's, I think, because I feel like I should be able to do something about that. This is where I can have impact. I don't have to fix the system. These are how I'm practicing medicine. So I've tried to focus on the cognitive errors, the sharp end of medicine. I looked at 100 cases of diagnostic error to try and figure out, why we have these cognitive errors. And at a big, broad overview kind of level, this is what I found. Every once in a while, it was a knowledge problem. Whoever it was didn't know about the disease that they were seeing. And one of these was my own case. It was a patient who had Fournier's gangrene, which is this nasty infection that you don't want to get. But I had never heard of that. And the patient wasn't diagnosed for over a week until the urologist came around and said, oh, this is a classic case of Fournier's gangrene. So that happens, but not commonly. There are problems with data gathering. So you miss something in the history. Your physical exam technique is not good and you miss something in the physical. Or like in the Rory Staunton case, the CBC result is not available. That happens too. But you see that the biggest chunk of the pie, like in Gordy Schiff's study, is in the synthetic phase, trying to figure things out, trying to figure out what is the diagnosis, what's happening here. 83% of the time, that was the major problem in the 100 cases that I studied. And it gets to the issue of how doctors think. So I'm sure you've seen this 100 times by now, but this is the going hypothesis of how doctors think. It's how we all think. It's how we approach any new problem in our day-to-day lives. It starts off with whether we recognize it or not. There's this little recognition center in our brain. It lights up with functional MRI. And if you recognize what's going on within 100, 200 milliseconds, you know the answer, you know what to do, you know the diagnosis. And this is system one, the ability that our brains have to recognize and problem solve subconsciously. It's automatic. You're not really consciously thinking about this at all. It just happens. And this is how experts think. If you don't recognize what's going on, you have to stop and think. You have to deliberately consider what's happening. You have to devote some conscious thought to the process. And we all know how to do that. We're decent at it. We're not great. And, you know, in medical school, we all start off in system two. We haven't seen anything. We don't know anything. But after we learn some things and we see things and it repeats itself, we get better and better and better. And things that used to be system one, now we can do subconsciously, automatically using system two. So that's kind of the dual process paradigm. And in day-to-day life, it's, you know, a little bit of both, and it all works pretty well, and we come up with a diagnosis. The problem is that neither one of these is perfect. They're both error prone, which is very interesting from a psychology point of view, and very sad because it leads to a lot of diagnostic errors. So these are some examples in the 100 cases that I reviewed of the kinds of breakdowns in cognition that are common and lead to diagnostic error. The most common one is this one on top. You know, we call it premature closure, but there's many other terms for this, like, I guess, jumping to conclusions or whatever. And this is, you know, like falling in love with the first puppy. Life is short. The minute we've solved that problem, the minute we have the right word for the crossword, the minute we kind of know what the diagnosis is, we are happy, we're moving on. And Herbert Simon got the Nobel Prize for this concept in economics. He called it satisficing, which is a great word, terrific, satisficing. And we do this all the time. It's human nature. And in healthcare, in diagnosis, it means that we do not stop to create a differential diagnosis for what the other possibilities would be. That would be the opposite of satisficing. That would be optimizing. So instead of optimizing and thinking of other possibilities, we satisfice, and we're happy with that diagnosis of gastroenteritis. Another common problem are context errors. If you're not in the right context, you have no chance of making the correct diagnosis. A colleague in our field, Pat Crosscarry, has a paper. It says context is everything. And he's completely right. So they were in a GI context, both the pediatrician and the ER people. They're hearing this story of vomiting, and if you're vomiting, you've got a GI problem. So gastroenteritis makes a ton of sense. To get to sepsis, you've got to escape from that GI context, which is not an easy thing to do. And, you know, if you've studied aviation disasters, you see these context errors all the time. The pilot thinks he's at 10,000 feet, he's at 1,000 feet about to crash into the mountain and hit the mountain goat there. They think there's no ice on the wings, but there is, you know, over and over and over, lots of context errors in every kind of disaster. Anchoring, you know, once you've come up with something, you kind of stick with it. You know, it's kind of difficult to move on to something differently. So gastritis, okay, you know, okay, that's good. I don't have to think of anything else. And a big problem that we're starting to recognize more and more, especially in terms of health equity and disparities in healthcare, is this problem of affective bias. And this is when our emotions get in the way. If we're seeing a patient that we don't like, and it may be consciously we don't like them, or it may be subconsciously we don't even realize it. It changes how we think about things, and it affects the diagnostic outcome. So these are just some of the things that our brain can do that detract from optimal diagnosis. And if you get interested in these, you know, so-called biases, it's a fascinating area. You can go to Wikipedia and get the latest compilation. Here's the one from a couple of years ago. This is 5 years old now. And at that point, there were already 150 different cognitive biases that had been identified, and I'm sure there's more now. I'm very impressed by the way E.T.L. Dror categorized the likelihood that these biases will have an impact and the situations that make them more likely or less likely. So what he's saying here is down at the bottom are all these human tendencies that we all have, but there's personal factors, clinician factors. So I may be more likely to be biased by some of these things than you might be. And there's system factors. Maybe there's something about our work culture that favors or disfavors tendency to be subjected to one of these problems. And there are certainly factors about the individual case, how urgent it is, how complex it is. So this is an interesting new way to incorporate consideration of whether these cognitive biases are a problem. And another problem that kind of drives me a little crazy is overconfidence. Physicians generally are supposed to be confident. If you don't convey a sense of confidence in what you're doing, patients don't trust you. So this is kind of ingrained in our training that we want to end up being confident and seem confident. And being confident is part of human nature. In fact, probably overconfidence is part of human nature. You're all familiar with the data. If you ask people, how well do you drive compared to the average driver, 73% of us are better than the average driver, which is impossible. And the same is true if you ask academics, professors, 80% of us think we're in the top quarter of our professional standing, which is also impossible. And the way this plays out in diagnosis is important because we get very distorted feedback. If a patient is doing well, you see them again, they come back, great. If they're not doing well, and especially if they're harmed, they are in all likelihood not going to come back, and you will not know about it. They will go find some other doctor, some other healthcare system. And so the feedback that we get is distorted. There are no more autopsies. There just aren't in the vast majority of healthcare systems today. And that's too bad, because there is nothing more powerful in terms of a lesson than seeing your own patient on the autopsy table and them showing you something that you missed. And a big problem in this regard is that we're just not well calibrated. And what I mean by this is, it would be nice if you're sure about a diagnosis, if it had a high likelihood of being correct. And if you were unsure, that it would have a high likelihood of not being correct. And turns out it doesn't work that way. Catherine Schultz has a great book. I would recommend it. It's called On Being Wrong. And she asks this question: what does it feel like to be wronged? Well, you say, I don't want to be wrong. People will think less of me. It'll be embarrassing. And Catherine says, nope. What it feels like to be wrong is exactly what it feels like to be right. Because until somebody proves to you that you're wrong, you feel like you're right. This is how we go through life. We make 1,000 decisions every week, and we don't get great feedback on them, but we move along on the assumption that all of those were correct. And by and large, they are. But our calibration is not good. And it was driven home to me in this study that was done in an ICU by Pobreger. He asked the doctors in the ICU after their patients died, what do you think was going on and how certain are you about it? And what was found is that the physicians who were completely certain about the cause of death were just as likely to be wrong as the physicians who had major uncertainty. They were both wrong about 10% of the time. So our calibration is not great, and very few doctors realize this. Okay, so now you know a whole bunch about diagnostic error, and you're in a pretty good position to try and figure out what went wrong in the Rory Staunton case. So, kind of roughly and quickly, if we do a root cause analysis, what were the cognitive problems? Well, knowledge, I think they knew about sepsis. ER doctors know about sepsis, so do pediatricians. The data collection was incomplete. They didn't ask about, the skin thing, or they didn't document it. And basically the problem was, again, in that synthetic phase. They had their data, they just didn't put it together entirely correctly. They were in the wrong context. They thought it was a GI case. There was premature closure. There was no differential diagnosis listed. And, the boils down to, I just didn't think of it. There's a famous paper in our domain by George Bordage, Why Did I Miss the Diagnosis? That's the title of the paper. And the conclusion is, well, I just didn't think of it. And it's absolutely true. That happens a lot. Well, how about the system things? Well, it would be great if the lab results would have been available quicker, a better plan for follow-up, some way for them to get re-engaged. And was there any learning? Well, there was actually. The healthcare organization where this took place did a root cause analysis, and they did a good thing. They said, nobody's leaving our ER anymore until their blood counts and their critical test results come back. And that's great. So they fixed something forever. And I love that. What they did not do was say to themselves, hey, I wonder if we're having these diagnostic errors every day in their ER, which they almost certainly are. And that didn't happen. So they view this as a one-off event, and they're moving on. So what it boils down to is that we have a huge problem with diagnostic error and tens of thousands of people harmed every year. ECRI concluded that diagnostic error was the #1 patient safety problem in their 2018 analysis, and they reiterated this in 2019 and 2020, the #1 patient safety problem in the United States today. And, it's interesting to be talking to you because you've been talking about high reliability, and where does diagnosis fit in this concept of high reliability? And I'm not an expert in high reliability at all, but it'd be my initial assumption that if high reliability is over at this end of the spectrum, diagnosis is at the completely other end of the spectrum. You could not get further away from a high reliability process than diagnosis in healthcare. So, like in aviation, they use the same planes, the operations are all standardized, the pilots are all trained to a very high level of competency. And if there is a problem, if there is a concern, if there is an accident, there's a tremendous amount of learning that takes place. And thank goodness. So at this point of time, the risk of my dying on an airplane crash is somewhere between 1 in 10 million and 1 in 100 million. So thank you, thank you, thank you. But if you think about diagnosis, our training is idiosyncratic. Every medical school is different. Every trainee will see a different spectrum of cases. Our skills vary. There's very little learning once you get out of school. And as a result, there's a lot of errors and there's a lot of harm, and this is not good. I've tried to kind of think about, well, what are the pillars of high reliability? How about preoccupation with failure? Well, we don't see that at all. We just assume we're doing great. Everybody assumes, yeah, we're fine. We're making all the right diagnoses all the time. And do we have a culture of safety? Well, absolutely not. We have a culture that focuses on remaining financially viable. And the only exceptions to that are in the few large health organizations, Kaiser Permanente, the VA. There are a few exceptions where there is starting to be a very nice culture of safety. And these are the role models. I wish there were much more, but maybe there's a handful. What about the other 5,000 hospitals? In high reliability, there's a reluctance to simplify. Well, I've already shown you that in diagnosis, we go the opposite direction. We tend to satisfy. We simplify all the time. I'm going to skip resilience and come back to it. I already talked about the problem addressing system shortcomings. Forget it. There's widespread normalization of deviance, deference to expertise, sure, but most care is delivered by non-experts on the front line. Robust measurement, feedback, and learning. There is no measurement right now. The feedback is distorted and there's almost no learning. Equivalent actors, I don't think so. There's different depending on what doctor you see. The one bright spot here, I think, is resilience. So this is a key feature of organizations that have high reliability performance. And it's interesting to me that I think in healthcare and in diagnosis, the clinicians really are trying to do a good job. And given the complexity of the process and all the challenges that they face, I think they really do a good job. And there is evidence of resiliency, at least at the personal level. So a little bit of encouragement there. All right, well, that's the story. Very sad. Where are we? We are not in a good place. What are we going to do about this? And very briefly, I'd like to review some of the ideas we have about how to remedy the situation, how to improve diagnosis. And it's based on kind of, what we've been talking about. We have system-related problems. What can we do to fix those? We have cognitive problems. So what can we do to optimize clinical reasoning? Fixing education would be nice. There is no course on diagnosis, it's sad to say, in medical education right now. And the National Academy would say we should focus on teamwork. That was their number one recommendation. I haven't talked about it yet, but you know the importance of teamwork in aviation. And their proposal is if we just had much better teamwork, we could avoid a lot of diagnostic errors. And I really love that idea. But what I'd like to focus on is just one of these, because we don't have time to do them all. I'd like to talk just a little about what we could do to improve cognition. What could I do personally as a physician? So I told you that the problems are these cognitive biases, our human tendencies, problems with rationality. Well, the solutions are pretty straightforward. Reflection. What if we just stop to think a little bit more? What if we got more second opinions? Wouldn't that be good? We bring fresh eyes to bear on the case. Maybe I wouldn't think of the right diagnosis, but maybe the second person would. And decision support, wouldn't this be helpful? And I think all of these have a lot of potential. So briefly, I'd like to go over them. What about this concept of reflection? All right, so here's what I'd like you to think about. When's the last time you in the audience took a multiple choice test, like your board exams or your certification exams? What instructions were you given? Like just, if you're facing a tough question, just pick the one you think's right, or really go back and study those ones that you aren't sure about. Should you trust your intuition, or should you think about it a lot? And when we do these kinds of polls, a lot of people say, okay, I was just told to trust my intuition, and that's how I did it. And other people say, okay, I went back, and we weren't sure what the answer was. So this was a research study that I did along with the people who administer the American Boards of Internal Medicine. So this is a test given to third-year residents that are as smart as they're ever going to be. And this is the test that says, yes, you are board certified in internal medicine. And it's done on the computer, so you can look to see what happens. And what we found is that the people who went back to look at a question they weren't sure about were twice as likely to change an answer from wrong to right as vice versa. So it's a little complicated, and it was true for easy and hard questions. But if they went back, they got more questions right. They got a higher score on the test. So this advice to just trust your intuition and move on is not good. If you've got this little inkling that it's complicated and it needs more thought, you should do that. You should go back and look at it. And it turns out this exact same kind of study has been replicated a half a dozen times over the last couple of decades. So stop and think is pretty good advice. How about second opinions? Well, this is good advice too. We know for a fact that this works. If a second radiologist, a second pathologist looks at the films or the slides, the diagnosis changes a certain percentage of the time. And the same is true in internal medicine. So studies done by Best Doctors, which is a company that provides second opinions, found that almost 7,000 cases, the diagnosis changed 15% of the time when a patient was seen by a different internist. And a systematic review of studies of second opinions, similar kinds of findings. The diagnosis changed frequently, 10 to 62% of the time. So second opinions are great. I'm a huge fan of getting a second opinion. Now, how about decision support? So you've heard a lot about decision support in healthcare today, and this is how it works in terms of diagnosis. There are plenty of systems out there and new ones coming online almost every month. These are the three leading ones, and I do not have a financial interest in any of them. And they work like this. You bring up the app, you put in the key features of the case, fever, mottled skin, vomiting, that was Rory's complaints. And within a couple of seconds, it gives you some things to think about over on the right. So what's the number 3 thing on the list there? Group A, streptococcal infection, which is exactly what he had and exactly what he died from. This is a study that was done using Isabel in a pediatric ICU. The residents on their own got the diagnosis right 89.4% of the time, and with Isabel, 92.5%. So you can look at that and say, that's not a very big difference. But if you're a parent, if you're a patient safety person, you look at that and you say, wow, instead of 10 kids at risk for harm, it's down to 7 or 8. And I would propose to you this is exactly where we are in healthcare today. We get it right 90% of the time. How are we going to get to 95%? We have to do something different. We have to use decision support or get a second opinion or stop and think or any of the other simple things that we could do to try and improve the process. They are not that difficult. They're not that expensive. Another study of decision support, looking at the impact of a system that based the recommendations on BMJ best practices. And again, the diagnostic accuracy rate went up, the days in the hospital went down, and the length of stay was shorter. So we have lots of potential solutions. The problem is almost none of these are being used anywhere. There's almost no research funding available for people to try these out. And we're just at the starting line in terms of figuring out which ones work and which ones work the best. So we're kind of at this impasse right now. We've learned a lot about diagnosis and diagnostic error, but we haven't yet done much to fix the problem. If you go to a hospital and say, hey, this is a big deal, you should do something, they will say, I have other worries. You should go talk to the doctors. They're the ones making the mistakes. And if you go see the doctors, they say, hey, I don't remember the last case of diagnostic error I made. I'm pretty good. And the accrediting agencies, the Joint Commission, CMS, if you look at the surveys they conduct, they're almost exclusively 99+% focused on management and treatment. There's almost nothing in these surveys about diagnosis. So we need help. We need help from people like you, people who understand safety and quality and high reliability and how this could be applied to improve diagnosis. We really do need help. This was the statement, the final statement from that National Academy report. We have to do something. Improving the diagnostic process, it's possible. It's a moral, professional, a public health imperative. We need to address this. So thank you all very much for your attention.